future of healthcare has arrived. Artificial intelligence and machine learning are transforming the practice of medicine and improving patient outcomes. This is Smarter Healthcare with AI. Conversations with Dr. Hassan Tetteh as he shares insights into the healthcare of tomorrow and how we can help create it today.
My guest today is Dr. James Cimino, the chair of the Department of Biomedical Informatics and Data Science at the University of Alabama at Birmingham School of Medicine. A board-certified internist, Dr. Cimino has had a distinguished career in academic biomedical informatics, literally writing the textbook for our discipline, holding positions at Columbia University, the NIH Clinical Center, and the National Library of Medicine. He is internationally renowned for his influential contributions at the intersection of medicine, computer science, and information science. Dr. Cimino, thanks for taking time from your busy schedule to speak with me today.
Happy to do it.
So the last time we talked, ChatGPT was not sort of at the forefront of everyone's mind. We certainly talked about artificial intelligence. You and I have had the opportunity to serve on a bunch of different committees and help to inform some of the policy and initiatives at the National Library of Medicine, at the National Institute of Health, and work in RWJ and things like that, Robert Wood Johnson Foundation. So if you were to sort of look back on the span of your career, how has the field of biomedical informatics evolved over the course of, let's say, the last 3 years in comparison to perhaps the last 10 or 20?
So the major breakthroughs, I think, if we go back to the early days, one of the major breakthroughs was the advent of the internet and the World Wide Web specifically, for a few reasons. One is that before the World Wide Web, if you wanted to do a literature search, you were pretty constrained to going to the library, looking in a physical book for the year under headings that you were interested in, finding articles, going to the shelves, and if they weren't there, going to the librarian and getting an interlibrary loan. But then there was an online search thing that only the librarians mostly used. And so getting an article, finding articles to answer questions was a week-long process. It wasn't an instant process. And so, we started bringing things to the point of care. You get 25 floppy disks and load them on your computer, and now you've got a copy of Harrison's Principles of Internal Medicine or something. And that was pretty revolutionary. But the thing that just completely blew all that out of the water was the advent of the World Wide Web, and for two major reasons. One was that there was a lot of information out there, but you could never access it. So the web made it accessible, that people were willing to share a lot of stuff, or you could pay a reasonable fee and get access to stuff. So suddenly you could get those things. The second was that the World Wide Web interface, that is the combination of HTML to build some kind of a user interface and URLs to connect you to other sites and resources, really lowered the energy bar to be able to get access to things so that anybody could create a web page in a word processor, Notepad if they wanted to. They could create something, or they could use something that they wouldn't have to know HTML at all. They could use a WYSIWYG editor to design and say, put a box here and put a link here. And suddenly everybody's created user interfaces that not only a human can communicate with, but we'll get information from other places and connect things the way they'd never been before. To give you an example was DXplain was a program I worked on at Mass General when I was a fellow, and that was a medical diagnosis program. And there were other programs around, and one of the challenges of using them was just that the user had to put all the information in. There wasn't a way to get information from the electronic health record. Even the Iliad system at University of Utah and LDS Hospital, although the developers had built both the EHR and the expert system, they couldn't get the information to be exchanged. DXplain got put on the World Wide Web early on, and I was building info buttons early on. And I went to see, DXplain's on there. And I looked at it and I said, look at this. The way DXplain works is you put in findings, and when you hit enter, the findings are actually listed in the URL, and then it gives you the differential diagnosis. I said, I could build that URL myself using my lab data and translating lab findings into DXplain findings, so I could create a DXplain button. It took like 1 day to do that. And we went from not being able to do anything to connect systems together to being able to do it in a matter of a few hours or a few days. Really, I mean, that was, that just was world changing. That was a huge change. The next one was, and some of this was happening simultaneously, but electronic health records, and they were around and they're coming along, and actually some innovations were occurring. The Affordable Care Act then, of course, sort of catapulted electronic health records to the fore, and suddenly everybody's buying existing systems. It stifled innovation to a certain extent because the hospital's health systems wanted to buy something out of the box that was ready to go. And, did it do billing and did it satisfy the requirements for meaningful use and so on? And if they check off those boxes, boom, let's get it, collect our money. People weren't going, is this really going to change how we take care of sick people? And I was like, yeah, we'll figure that out. Yeah, we'll figure out how to do that. So we still have a ways to go in terms of figuring out how to make the most out of what electronic health records can do. But that was a life-changing thing too, because suddenly electronic health record data is now available and ubiquitous and at least available for care of the patient, so that we're not running around looking for paper records and, no, sorry, it's locked up in billing tonight, you can get it tomorrow. Or we lost that record, or it got wet, or whatever, or we found it, but we can't read his handwriting. So now we have something, that really has changed the ability of teams to take care of patients in across geographic space, so that we couldn't do before. And that availability of that information then is supposed to be useful for research, for quality control, for all kinds of things. And it is, but there's still room for improvement based on the fact that, they weren't created to do that. They were created to record the things that people wanted to say and the billing that we had to do. And we still have to get to the point where we go, all right, now let's build a system that's really going to help take care of sick people. The latest thing now, which is this generative AI and large language models, which, like the advent of the World Wide Web, have lowered the bar of access so that anybody can now ask a question of a large language model and get some kind of answer. Whereas before you had to find an expert system and you had to build an expert, whatever it was. Now anybody can just talk to these things. And we're already kind of used to doing that with things like Google or other, search engines, or, these smart speakers, and, where we feel like we're kind of talking to it. Although we certainly talk to my smart speaker in a way that's much more like talking to a web search engine, where I don't even have to say a sentence. I just blurt out a bunch of, relatively rare nouns that I know are going to be in the answer that I'm looking for, and I'll get something useful, but I'm not expecting it to compose an answer for me. Now, the large language model, I can write something and expect to see something that will not just be, here's something you should look at. Your answer may be in there, but it's actually giving me the answer. So and anybody can do that. And anybody with a little programming background can write an API to link their own program or their own data and say, oh, I have a whole bunch of stuff I want to pass through this generative AI and have it generate stuff for me. And I don't have to do it one at a time, typing it in, cutting, pasting, whatever. I can just, dump it all in here, and out comes all these things that I could then line up. So if I say, I've got a patient record, and it's got 2,000 documents in it, and my patient would like to read their record, but unfortunately only has an 8th grade education. So what I want to do is pour these documents in and just say, take each of these documents and rewrite it for somebody with an 8th grade education. Don't try to synthesize across. Don't say, oh, based on this x-ray and your history of whatever, we know. No, don't do that. Just rewrite each document and give me the new document so I can show it to my patient. That's a tremendous, tremendous benefit, and it takes so little effort. And once you spent the 1 hour to learn how to write the API and another hour to build it, you could do everybody's record on the planet. So the amount of time effort you have to put in per patient is vanishingly small. So I think that's a revolution that we're still learning, how to deal with it. It's sort of like, radium. When they figured out what radium could do, and they were like, wow, look at this thing. You can cure toenail fungus with radium. Man, this is great. You can shine through your hand and look at your bones. You can, kill whatever. I mean, then eventually it was like, yeah, you know what? Putting it on your toenails or even on your watch face, not such a good idea. So let's back off of that. But it's really good for whatever. So we've got this thing now. We're kind of at that level.
So that was an excellent segue into our podcast of smarter healthcare with AI, because you end with AI as being one of these major breakthroughs. And I'm very fond of sharing when I give talks and even in the setting of podcasts or interviews, 5 super forces which I think are impacting healthcare. And you essentially enumerated 3 of them without me prompting you or without us having a prior discussion about this. And the 5 super forces I like to allude to are the ones you mentioned. You mentioned AI, large language models is sort of the newest generation of that in generative AI. You talked about the data, and you talked about it in the EHR and the fact that we have this readily available data source right now with everything being electronic and digital. And then you talked about connectivity, because that's a very big thing. Connectivity in the World Wide Web, the fact that we were able to be connected and collaborate across the world with our colleagues and build research and forward research and sort of mature research. And not only that, but get access to material. The other 2 forces that we haven't touched upon, which I'm sure you're still aware of, is investments. And I always like to say the last and most powerful super force is people. So there's lots of investments. You may want to talk a little bit about that. But I would say in the last few years, there have been quite a bit of investments in this technology, particularly in generative AI as of late, with private sector as well as the government and things like that, probably at a pace and scale that we've not seen before. In academics, where have you seen some of that investment, and how has it made an impact or not made an impact in your estimation?
So a lot of the investment that I've seen on the clinical end of the spectrum has been around, besides electronic health records, is the access to electronic health record data for research. There's been a lot of interest in doing that. And whether you're using a commercial warehouse connected to your EHR, or using something freestanding like I2B2, but access to patient data, now that people see they can get it, and it's sort of free in the sense that they didn't have to collect it. It was already collected for them. And there's a lot of it. People are, very excited about getting that. And I see investment in those kinds of things. So we have, UAB has invested in personnel to build, maintain, and our warehouse, and to provide service for users who need to get access to the data. So that's been a big investment. And, there's always been investment in supercomputing, but it's really, as prices are coming down and needs are going up, that's a continually elevated rate of investment in sort of the hardware side of things. So those would be the big ones. I think there would be more investment in personnel if we knew what kind of personnel we wanted. And, before the pandemic, Alabama was trying to figure out what it should be doing to invest in workforce around artificial intelligence, whatever that meant. And that was, of course, pre-generative AI stuff before the pandemic. And they really weren't sure what they were thinking about. They were talking about, we're going to teach people how to use AI. And I'm like, anybody ever have a phone? You're already using AI. What do you mean teach people how to use AI? I think, are we teaching people how to create AI? Are we teaching, how to use specific artificial intelligence applications? Or, it was a strange conversation, and it took us a while. There's a lot of smart people coming from different directions, and it took us a while to kind of find common ground and hammer out a framework to say, all right, AI means all of these things. And what are our goals? We're trying to, make sure people are using AI correctly, that they understand what it is. We want people who are going to be the creators of AI-based applications. So that means education at higher levels and PhD programs or what have you. And so, we were starting to get around there, and then the pandemic hit, and that was fallen by the wayside. But it was an interesting exercise that we thought about trying to define sort of the parameters for what it meant to invest in workforce. So we have a Bachelor of Science program in bioinformatics. And when I say bioinformatics, I mean the bioinformatics in the sense of sequence analysis and that sort of thing, not sort of the catch-all phrase for the field. So people learning very specific things, they're getting an undergraduate education. they may be getting enough to go out and get a job somewhere, but probably they're learning enough to know that they want to pursue that field and come back and get a master's degree. And then they will be able to go and, work for somebody analyzing their data and make a nice salary and be contributing to the world, good and all those kinds of things. But if somebody says, yeah, this program's not working very well and we're just struggling with it, and somebody goes, I know how to make this program better, then they suddenly become a developer of the technology. And we want to train people there too, because we don't want everybody reinventing the wheel. We want people to understand what's going on at that level and push the envelope, develop new methods, and then go out and either do research on it or start a company or, what have you. But the field is so diverse that it's really hard to say, well, we're going to train a biomedical informatician or even a bioinformatician or whatever. It's a very broad field. So it would be like saying, well, we're going to train, I don't know, an engineer. Well, what kind of engineer? Chemical engineer, mechanical engineer, electrical engineer, they get different training and it's the same in informatics. So I think people are struggling with who do we hire that's going to come in and solve these problems and then be ready to solve the next problem.
In your role as the chair of the Department of Biomedical Informatics and Data Science at University of Alabama in Birmingham, not only you espouse how you're training the next generation, but in your role right now as both a computer scientist and as a clinician, which discipline do you think you rely on most these days?
I would say that it's neither. It's the connection between the two. So I'm working with a PhD student who is trying to use electronic health record data to do her PhD thesis. And she's not a clinical person. She's got a master's in public health, so she understands health stuff, but she doesn't understand electronic health records in the sense of what goes in and what's really in there. And she's working with IT people who understand electronic health records, but don't understand clinical research. So she had this huge challenge of trying to communicate with them to say, well, this is what I need. And they give her what they think she wants. And she looks at it and goes, this is weird. Why does it look like this? And she goes and asks them, but she doesn't ask the question in a way that they understand where she's coming from. So I get in the middle and I say, okay, well, you got to understand that the reason that this problem list looks sparse is because the clinicians aren't putting every problem that the patient has on the list. Why not? Well, because that's not their job and it's tedious and they don't know why they would want to do it. So the patient's record's incomplete. Yeah, it's incomplete. For that moment, they put in the things that are important for that visit. And then it's like, well, I asked for people with this condition and they gave me this list and none of these people have the condition. I go, well, that was the admitting diagnosis. But sometime during the admission, they also got that condition. There's only one admitting diagnosis per admission. They put that in there for whatever reasons. You have to go deeper into the data and see where the other data are. So there's that bridge between, it's not even the computer science necessarily at that stage, but it will be. If somebody were to be doing machine learning, I just talking to a guy who was interested in doing machine learning on patients with certain condition, trying to predict if they were going to get another condition. And I was using my clinical expertise to say, well, what is it that would clue you into this? Is it vital signs? Is it, patterns of use of medications or health services or whatever, using that side and then say, okay, now here's how we would get those data and here's how we would train a system that could do that. So lots of people can work on either end of that. It's that connection, bringing that together that is really the challenge. And teaching people to do that, it's hard to do that. You can teach them the pieces and give them simple problems, but it's really experience in the workplace, I think, that ultimately gets people up to that level. It's really hard to teach them how to think on both sides with one foot on either side of the street like that.
You said that you don't rely on either one of them, but you rely on both of them. Because in your research, you do a lot of research on understanding the needs of clinicians and patients. In fact, you just alluded to that with the examples you gave of the folks that you're mentoring. So how, in the context of smarter healthcare with AI, would this sort of new technology we have that's a little bit more powerful than what we had before, how might AI impact that doctor-patient relationship as far as you see it moving forward? And with this exchange and this, sort of engagement between the doctor, the patient, the data, and the and the clinician and sort of our technologists? Where do you see that evolving, and how is that going to mature?
Well, some things that are happening now are, seem pretty obvious. So the clinician talking to the AI and saying, especially if we've given it the patient's record, and we've given it lots of other patients' records, we might be able to ask it, what's going to happen to this patient? And it could say, well, there were a lot of other people like this patient that got this drug, and here's what happened to them. I'm always astounded at what something that's really just saying, what's the next word? What's the next word? That's all it's really doing is saying, well, all right, that's the first 900 words. What's the next most likely 901st word? But somehow they generate images and they write computer programs and things like that they weren't trained to do. So I never underestimate what can come out of these things in terms of skills that they can emulate. So certainly I think clinicians will converse with them to get medical knowledge, help them work through a problem and say, well, what about this? But how do I explain this thing? And it can say, well, people with this often have this other thing and make connections. On the patient side, patients have questions about their health. What do I do? I just had this happen to me. What can I expect in terms of recovery time if I get the surgery, or should I do physical therapy? Well, how long will that take? And, have an exchange on those kinds of things. In terms of bring the doctor-patient interaction, I think we still have a lot to learn about how we can do that. One thing that would be great is if we could figure out how to get large language models to interview patients, to collect information from them that wasn't just overwhelming and useless. So, we give patients questionnaires and, they're sitting in the waiting room and you say, here, fill out this questionnaire and, check off all the things that are bothering you and we'll give that to the doctor. And man, when I would get that when I was in clinic at Columbia, I hated that because a lot of patients just check everything. And now you're kind of obligated to go, really? Your tongue itches, and you would have all these things you had to pursue because now they're part of the record. And you feel like, then you have to sort out which are the most important, which ones are really, did you really understand this question? And, it adds a lot of overhead to the process to say to the patient, tell me everything that could possibly be wrong so I can sort that out. But a language model could figure out how to focus on certain things and how to prioritize things. And the generative part could then prompt questions to fill in gaps so that, here are things that we don't know about you that would be helpful to know. Have you been traveling? And somebody says, yeah, I've been traveling. They said, have you been traveling anywhere there's malaria? Well, the patient goes, I don't know where there's malaria. And the system goes, well, here's the places that typically have malaria. Did you go to any of these places? Well, I don't even know. No, I didn't go there, but I did go to Brazil. Oh, well, where did you go in Brazil? Well, I was only in Rio de Janeiro. Okay, well, did you go out in the country? Whatever that is, then you could have a system that collected data from the patient, and then the physician goes, tell me what's going on with this patient. And it doesn't tell you everything. It tells you, the important things, and then you can say, well, wait, what about travel? Where did you go? Oh, it tells you more, and you have a conversation as if you were having with a person who has a little training and is just collecting a lot of information on the patient. And the computer doesn't care if the patient goes on and on about things that aren't going to be relevant. But you never know when it's, the patient might tell you this long story about how much trouble they're having, moving to a new house. And they inadvertently talk about which things give them chest pain when they were moving. And now suddenly that moving story is relevant. Oh, really? Carrying that, refrigerator up the stairs gave you chest pain. Suddenly the refrigerator doesn't matter, the chest pain does. And so we can filter through that. And get at the me. So I think maybe people are working on that now. I wish I had time to be working. That's what I'd be working on if I had unlimited time, because I think that would be a fascinating area to explore.
Yes, I could speak firsthand that there are definitely some people working on this aspect of the doctor-patient relationship that you're really talking about, which is basically making the visit more efficient. So by the time that engagement and encounter occur, there may have been, just as you mentioned, an opportunity for the patient to engage at their leisure with as much time as possible with the large language model that could also help get information to fill gaps in with just prompting and gathering information. So there's a lot more focus and potentially even more information gleaned from that encounter because this engagement happened before the actual visit. Okay, doctor, hang on. We have to take a break, but coming up next time, Dr. James Cimino will talk about some of the tangible ways large language models can help physicians on a daily basis.
When I'm working in the clinic, and I need to know how to do something, if I'm lucky, I've got this great nurse next to me who knows all the answers. But sometimes she's out, and I hate when she's not there, because now I don't know how to do anything. And so I need a generative AI to take her place when she's not there. So, and also to be up on, what's the phone number for this officer? How do I schedule this patient for this thing? Or we're out of this thing. What can I use as a substitute for this patient? Or what home service is available for this patient who has this kind of insurance?
This has been Smarter Healthcare with AI. If you'd like to find out how to bridge the gap between medical experts and tech innovators and discover how AI can make us healthier and more human, go to Tetteh.com. Smarter Healthcare with AI with Dr. Hassan Tetteh is a production of Forbes Books.